Thank you for this opportunity to speak today. My name is Fraser Henderson. I'm a neurosurgeon. I was at Georgetown for 14 years. I've been in private practice for 6 years. And EDS is what I mostly live and breathe. When I was at Georgetown, I really enjoyed the complex neurological syndromes, and they sent them all to me. And typically they had chronic severe pain, minimal radiological findings, multiple systemic dysfunction. And it wasn't until I realized that all of these fell within the rubric of Ehlers-Danlos syndrome that I was able to really establish a more rational treatment plan. But you must recognize the EDS to precisely treat the problem. EDS may present, obviously, with many different neurosurgical problems, and in fact usually does. It's not just one problem. The lax ligaments and degenerative discs underlie the bending and stretching of the nervous system. I'm going to discuss some of the neurobiology of that, discuss the outcome of 2 studies of patients who underwent craniospinal fusion, and then discuss some other neurological conditions like tethered cord. Most patients get sent to me with complaints of headache, and in addition to all of the normal complaints, all of the normal causes of headache, I always think of these problems as well: Chiari, atlantoaxial subluxation, temporomandibular joint syndrome, occipital neuralgia, thrombosis of the sinuses of the brain, hypercoagulability, Hughes syndrome, migrainous TIAs, pseudotumor cerebri, orthostatic intolerance, limbic encephalopathy, and neuropochettes and other neuroinflammatory disorders, tethered cord syndrome, mast cell release disorder, neck muscle spasms, and of course craniovertebral instability or floppy head syndrome, for which I'll emphasize my remarks today. Well, Chiari malformation occurs in a lot of EDS patients. In fact, they're now saying it's 1% of the population. And it's simply this descent of the cerebellum below the aperture at the base of the skull, the foramen magnum, causes pressure on the brainstem, and therefore presents with a cervical medullary syndrome, which is characterized by headache and neck pain, worse with laughing or straining, double vision, vertigo, tinnitus, ringing in the ears, nausea, dysarthria, difficulty with speech, dysphagia, difficulty swallowing, decreased gag reflex, choking, altered sleep architecture, weakness, change in gait, clumsiness, sensory deficits, and so on. The treatment of Chiari malformation is simply a decompression, and a number of variations of that. The problem is that about 10 to 40% of those surgeries fail, and that's in part because 12.7% of all Chiari patients by one study have a connective tissue disorder, but of EDS patients with Chiari malformation, almost all of them have some degree of craniovertebral instability. So if you have EDS and a Chiari malformation, you probably have craniovertebral instability as well. And a simple decompression is not going to improve you, it may make you worse. But craniovertebral instability is not limited just to EDS, it's fairly common out there, and there's some very large studies. Menezes reported on congenital craniocervical anomalies and also osteogenesis imperfecta, and he talks about the anomalous anatomy contributing to the formation of granulation tissue or pannus, which causes compression of the brainstem and spinal cord, and this in turn exacerbates the whole condition. And Atul has presented a series of hundreds of patients similarly with connective tissue disorders with this pannus formation and craniovertebral instability that require fusion stabilization. It's not limited to humans. The Cavalier King Charles Spaniel has this condition, and they have a ventral brainstem compression and undergo surgery for that and posterior fusion stabilization. Gold talks about basal invagination arising from ligamentous instability and a chronic microtrauma, and that there's a reverberating process where this microtrauma increases the neurological injury. The neurological injury increases the instability and the pannus formation. And he also cites contributions from poor nutrition and vitamin deficiencies, which is a good segue to Ehlers-Danlos syndrome, where at least half of the patients that I see have vitamin deficiencies. Now, a decade ago, Professor Graham and his colleagues noted that many or most of the EDS patients had significant neurologic deficits, and he raised the issue of CNS involvement at the craniocervical junction. So how would ligamentous laxity cause neurological deficits? I'm going to talk about that. In a nutshell, lax ligaments result in deformation, stretching of the brainstem. Now, my interest in all of this actually began 22 years ago when I was doing a fellowship in London at Queen Square, and I was asked to look at the histology of 10 patients who had died as a result of basal invagination, the spine pushing upward through the skull base, pushing on the brainstem and causing death. And I was told that I would find vascular ischemic changes, write that up, and we'll move on. And when we looked at the histology, we did not find vascular or ischemic change. We found these other little bulbs here, and at that time we didn't know what they were, but we opined that they were the result of stretch injury. And we published this, and at that time not many people really went along with that notion. But these are small silver staining axon retraction balls where the nerves separate and pull up, and they result from stretching of the spinal cord. Now, when the normal person bends his neck from full relaxation to full flexion, he stretches the spinal cord up to 17% of its length. That's a strain of 0.17. And when you achieve a strain of 0.2, you start getting into the pathological zone where there's a permanent deleterious injury to the spinal cord. And this has also been described by Brieg and myself, published 4 years ago, in the brainstem. So if the brainstem is subjected to increased bending, it causes a stretching and the same stretch injury. This axial stretch is compounded by out of plane loading, such as from a retroflex odontoid, or anything pushing from the side, anything compressing the brainstem or spinal cord. Now, a few years after we published our work in London, Pavlicek showed that stretching nerves causes formation of these axon retraction balls. So here's the normal nerve, axon, and the small microfilaments, microtubules and neurofilaments, and after stretching they become clumped like this. And Satman showed if you stretch a mouse optic nerve, after 3 days you see these axon retraction balls, and after 10 days you see loss of neurons and apoptosis and so on. So stretching hurts the nerves. Now there are also more temporary changes in ion flux. Nerves work because of the electrical conduction, and if you stretch a nerve, you increase the distortion of the sodium channels, increase sodium influx, that alters the calcium channels, and that results in this deleterious influx of calcium into the nerve that is very harmful. And stretching also causes the genes to upregulate, and Arendine showed that N-methyl-D-aspartate is upregulated in stretch injuries. So, in effect, a stretch injury is an epigenetic stimulus to nerves. And if you look at electrical conduction studies, this is the amplitude of an electrical response. If you stimulate a nerve, you get a waveform here. Now, if you apply a stretching force, a strain, you'll see a decrement in the amplitude, a decreased waveform. And if you apply a rapid strain, you see a much greater decrease in waveform. And that's the basis for whiplash injury. Now, we showed that the odontoid pushing on the brainstem causes deformation and sleep apnea. And when we removed the odontoid with a transoral odontoidectomy, all of those patients had a resolution of the sleep apnea, and we published that in 1994. So mechanical forces modulate gene expression and biochemical composition, directly affecting neurons, making them more sensitive and more vulnerable to injury. And we think that this injury underlies many of the deficits we see in floppy head syndromes. And all of these notions and ideas were published in the Journal of Neurosurgery in 2005 with colleagues from London and Cleveland Clinic. So what are the tools then that we can use to predict deformative stress? We can't cut patients open and do histology on them. Last year in October in San Francisco, we had members from all of these universities, and we achieved a consensus statement to decide consensus statements regarding craniocervical hypermobility and basal invagination. And we determined that the cervical medullary syndrome was an important manifestation of deformation of the brainstem. And this presented with headache, suboccipital or neck pain, double vision, decreased or blurred vision, dizziness, vertigo, imbalance, ringing in the ears or decreased hearing, various forms of dysautonomia, postural orthostatic tachycardia, syncope or pre-syncope, dysarthria, dysphagia, choking, altered breathing, altered sleep architecture, weakness, clumsiness, spasticity, sensory changes, gait changes, and so on. And these have been published in a book that we just brought out. And furthermore, the consensus statement went on to say that in assessing for potential basal invagination or for craniovertebral instability, that there are certain radiological metrics that the neurosurgeon might use that might be helpful. And these are the clivoaxial angle, the Grab-Mapstone-Oakes measurement, and Harris's measurement. And I'm not going to go into detail for them, but these are just tools for the surgeon to determine whether he can measure instability or measure the degree of basal invagination present. So I'll just show you the clivoaxial angle. That's that angle right here. Normally that's 165 degrees, more in extension and less in flexion. If that angle is less than 135 degrees, it's associated with brainstem symptoms. And Kim, Riekate, Klopfenstein, and Sontag in 2004 published on their series of patients with Chiari malformation. And these patients had all failed a Chiari decompression. And they found that their clivoaxial angle was less than 135 degrees. So they went in and performed a reduction and established a normal clivoaxial angle and performed a fusion stabilization. And 9 of those 10 patients showed an excellent improvement. Kubota also noted that in patients with Chiari malformations and syringomyelia, that the syringomyelia did not go away if the clivoaxial angle was less than 127 degrees. So clearly, this angulation of the brainstem is important in terms of brainstem symptoms and syringomyelia, presumably by virtue of the deformative stresses. And we also look at the Harris measurement and to try to measure the degree of slide of the skull backwards and forwards between extension and flexion. So here the patient's flexing his head slightly. There's a tilt of the clavoaxial angle. It becomes more acute, and there's more stretching of the brainstem and indeed of the entire spinal cord, and that stretching presumably underlies some of the neurological manifestations. So how do we treat craniocervical instability? Well, the first thing is to remember that surgery is the last option. We need to first rule out other things like multiple sclerosis, Lyme's, diabetes, nutritional deficiencies, especially vitamin deficiencies, which I think occur at least in 50% of EDS patients. Diseases like ALS, and we're finding that mast cell activation syndromes are very common and underlie not only headaches, but brain fog, confusion, and some of the other problems. So we like physical therapy. We actually we have some good physical therapists in town, and we also send our patients often all the way up to Rhode Island to see Mike Healy, who has been very good at diagnosing subtle levels of instability. But we like to correct the posture, strengthen the muscles, establish sagittal balance. Some of these patients need dry needling for muscle spasm. And then they have to alter, as you were saying, they have to alter their lifestyle and adopt a more prudent view of their lifelong activities to avoid trauma. They need a genetic evaluation, they need medical treatment of their pain, and they should all have a Genelex or equivalent study to see what drugs they're sensitive to, or which drugs they rapidly metabolize or slowly metabolize. There'll be more on that at lunchtime, right? Right. How much did you pay me for that? Is that?
Still, I had to take out a loan.
Okay. Actually, it was a trip to Bahamas, but I turned them down. So indications for craniocervical fusion. These are the ones I use. Patients should have a relatively severe headache or neck pain. If it's mild, then that's, it should be 7 or 8 or above in general. Brainstem symptoms. Significant symptoms of brain fog, cognitive loss, double vision, these kinds of things. There should be neurological deficits, weakness, sensory loss, hyperreflexia, and radiological evidence of a Chiari malformation or ventral brainstem compression or basal invagination or craniocervical instability. And then for the procedure, the patients are placed prone. We do sensory evoked potential and brainstem monitoring, intraoperative fluoroscopy, and we do intraoperative CTs. They undergo a suboccipital craniectomy, usually for low-lying cerebellar tonsils or Chiari. We place the screws in at C1 and C2, avoiding the vertebral artery. And in the EDS population, where the bones tend to be smaller, that can be a tricky proposition. But we have not had any, by the grace of God, any vertebral artery injuries. Then, after the wound is exposed and the muscle is somewhat removed from the bone, we perform a traction and then an extension and a posterior translation to normalize the relationship of the skull to the spine, put it into an ideal relationship. And then we look at a number of different measurements, and we go through this iterative process 3 or 4 times to get it just right. Then we apply this ugly metallic hardware to maintain that position, and we put in bone. I was putting in rib bone from the patient. Now I use allograft from the bone bank, and then I draw marrow from the hip and then we spin that marrow down to make a ultrafiltrate, and inject that into the allograft, and we think that improves the ability of that allograft from the bone bank to fuse. This is the wound at 7 days and 1 month. And surprisingly, even though we're removing 50% of the range of motion with stabilization, patients have not seemed to complain, and they have so much mobility at the lower levels that I don't think anyone's told me they could not drive a car or something like that. So what are the results of the fusion? These first results were from a study I did at Georgetown starting about 10 years ago. And we looked at a correlation of deformative stress with clivoaxial angle and other things. We used this, we actually invented this finite element analysis program to predict mathematically the stresses in the brainstem and spinal cord that develop during flexion. And at any rate, we noticed that following surgery, that the sensory-motor index improved, neurological function improved, the Kanofsky performance index improved, and the quality of life, physical and mental, with the SF-36 improved, and these all correlated with decreases in predicted stress. Well, that was just a small study. More recently, we looked at 20 patients, all with EDS, and who underwent a craniospinal fusion, and they presented 100% with headaches, 100% with fatigue, dizziness, muscle pain, arm weakness, joint pain, neck pain, balance problems, memory problems, night awakenings, upper extremity numbness, walking problems, hands, feet turning cold, leg numbness, visual problems. That's 73%, was going down in order of frequency. Leg weakness, vertigo, hearing, speech, frequency of urination, gastric reflux, swallowing, choking problems, and so on. Now, notice, by the way, about 50% of the patients had dystonias, which seem to be very common in the EDS population. And after surgery, the ones in yellow where more than 50% of the symptoms improved significantly. And that was vertigo, headaches, balance problems, arm numbness, dizziness, speech, neck pain, memory, and so on and so on. Now, there are a number of things that did not improve. Only 50% of tremors improved. Muscle pain, frequency of urination, fatigue, gastric reflux, and so on. A lot of these problems are due to other aspects of Ehlers-Danlos syndrome. Now, we asked patients, in looking back, would you still choose to have the craniovertebral fusion surgery? And all of them actually agreed, and we didn't pay them anything. This survey was taken by a third party, by a nurse who was hired just to do this study. And the surgery improved my symptoms and decreased my limitations. I think all but 1 or 2 agreed. So a couple of patients still had substantial limitations. Looking at headache, we saw a significant decrease, p-value of 0.001, from a preoperative headache of 8 to a postoperative headache of 4.5. So here's the headache in blue before surgery, 10, 9, 8, 7. And after surgery, notice that most of these patients still have headache. It's just controllable. So the surgery does not take away your headache for the most part. That's very important to remember. And keep in mind that headache results from many other factors. And when they have continued headache, I have to worry about the presence of all of these other conditions. Neck pain, substantially improved. His before surgery in blue, 7 to 10, and after, 2 to 6. But most patients still have neck pain. It's just better. Dizziness, substantially improved, still present. Same with vertigo. Walking problems. Most patients had very severe walking problems before. Afterwards, some mild walking problems. Balance, tremors. Kanofsky Performance Scale. Now, at 100, that's normal. Hopefully all of us in here are 100. At 50%, you're requiring considerable assistance, frequent medical care, and preoperatively, most patients, the average was 57, and postoperatively 71. So this was actually highly significant. 14 out of 22 improved, 5 no change, 3 just worsened with the various EDS issues. And there's, okay. Clivoaxial angle. Now, one of the goals of the surgery was to increase the clivoaxial angle by about 20 degrees, and we achieved that from a preoperative average around 130 to postoperative average around 150. Here's a happy story. A 18-year-old girl at that point, she was just starting her senior year. Her pain level was so high, it was 9 or 10 all the time. She couldn't stand up. She was so weak, and just testing her joints, all her limbs would pop out of their sockets, just testing her strength. And I really did not want to operate on this girl. And but family had been all over and had really decided to, and had researched the problem very well. And we did go ahead and do the surgery. And then this is the good end of the spectrum. Not everyone is doing ballet 3 months after surgery. But she did. That is a ballet recital she's getting ready for. She was valedictorian, worked her way through college in 3 years. Got married, recently got a job, recently promoted. So that's craniocervical instability. And we still have a lot more to learn. Let me talk about some other issues, other conditions associated with Ehlers-Danlos syndrome. C1-2 instability. That's where the C1 ring slides so much that it almost slips off the C2. Actually, this is C2 here, and here's C1. But with neck turning, these bones almost become dislocated. And if they became dislocated, that could cause a cord injury or even death. I found that there appears to be a syndromic manifestation of C1-2 instability. Neck pain and headache, much worse driving on bumpy roads, like around DC. Nausea, partial orthostatic tachycardia, dysautonomia, pain with neck turning. Severe pain just touching C1, C2. In fact, a little pressure of a C1, some patients will begin having a tremor or collapse or go unconscious. Others will just say they feel very nauseous and sick. They typically have decreased pinprick sensation all over the body. You can stick them with a pin. It says, yes, it feels sharp, but it doesn't hurt. There's often some clumsiness in the arms. They're much better with the neck brace, and confirmation is with a CT scan, like the one I just showed you. But these neurological findings can be quite subtle, as you can see, and hyperreflexia. So if you don't do a very careful neurologic exam, and if you don't suspect C1, C2, then you're going to miss it. And the treatment is placement of a screw, again avoiding the arteries into C1 and C2. They're the screws and fusion in between. I was taking bone graft from the hip and putting it there and then covering it with 2 little plates. Now I use allograft from the bone bank and bone marrow. Complications, I was having the graft site pain when I was taking the graft from the patient. Now we use the allograft. We usually mobilize the patient on the day of surgery, usually leave 2 days after surgery, wear a neck brace for 3 or 4 weeks. I've had 1 failed fusion, no hardware failure. Right, this is the first time I've ever really talked about this. It's in the literature and various different articles, but never related to Ehlers-Danlos syndrome. So in Ehlers-Danlos syndrome, there is disc disease throughout the cervical spine typically, and on a dynamic film you can pick up increased angulation and subluxation. And this can cause, without actually compressing the cord, spinal cord, it can cause significant symptoms of gait, bladder function, nausea, headache, even memory changes, speech changes. And Benzel, in a monograph in 2007, in the supplement to Journal of Neurosurgery, talked about the myelopathy of spondylosis over a deformity of the spine, which he says causes a kind of tethering and results in repetitive trauma, spinal cord distortion, and tethering. And it's important to obtain a dynamic MRI to bring this out. On a routine MRI, you might miss it entirely. So here's a routine MRI. And here's an MRI on flexion, and you can see the abnormal bending right there. And on extension, you can see that this vertebrae here is slipping posteriorly about 3 millimeters. This C4 vertebrae is slipping posteriorly on C5. And there's a little slip at other levels too, but that's the worst slip. And that results in cord compression. You would only see that on an extension view. White and Punjabi back in 1980 said that if you have an angle between 2 vertebrae, a resting angle of more than 11.5 degrees, you have a pathological condition. And again, these issues were published in our manuscript in Journal of Neurosurgery 2005. Now, I've pulled together a few really anecdotal reports from patients, and these patients with C2-3 instability had neck pain, headache, syncopal episodes, air hunger, tics, eye pain, thoracic pain, gait changes. And that was from a C2-3 instability, not what we'd typically be looking for. Findings for the C4-5 instability had a number of patients with this problem: headache, head pressure, vertigo, nausea, decreased visual acuity, dysphagia, difficulty breathing when bending forward, sleep. They tend to sleep with their head of bed raised 30 degrees. They have severe pain and numbness across the shoulders, especially between the shoulder blades. That's a C4-5 syndrome. Here's a patient who had just that syndrome. She was in 9 out of 10 pain all the time. We didn't know, and her symptoms of headache and nausea and brain fog, we attributed to pseudotumor cerebri. And so I was thinking of putting in a shunt, and then I obtained this film and decided that her problems were not due to pseudotumor cerebri, but C4-5 instability. And she went from being bedridden to up on her feet a few days later and neurologically intact, and went back to school and got straight A's. C6-7 instability, there's a paper back in the early 80s talked about the vertebral artery syndrome. The vertebral artery enters Chassagnac's tubercle at C6-7 and can cause things like occipital neuralgia, pain in the back of the head. And patients with this C6-7 instability can have not only the headaches, but nausea, vomiting, poor balance, twitching in the arms, disturbed vision, burning in the conjunctiva, a feeling of clogged ears, and arm numbness and weakness. So these are just a few symptoms of cervical segmental instability syndromes. And these are symptoms that neurosurgeons don't usually look for with a C6-7 instability. Tethered cord syndrome, another condition where we're stretching the spinal cord. And tethered cord is any condition where the cord is attached to the spine, causing abnormal deformation and stretching of the cord. And in the EDS population, this is because the filum terminal, the little thread that comes off the end of the spinal cord, is thicker and applies more stretch than the normal filum. And it's like a fishing line pulling in a fish. It just applies that constant tension. That stretching of the spinal cord is what's thought to cause all of the neurologic deficits. So in tethered cord syndrome in the EDS population, it's a clinical diagnosis, and that point was made very well, because usually the conus, the end of the spinal cord, is at the normal location. But there's weakness of the legs, low back pain, sensory loss in the lumbar and sacral dermatomes, a neurogenic bladder, confirmed by urodynamics, showing large post-void residual and sphincter detrusor dyssynergia. The history, remote history in childhood, shows multiple urinary tract infections, bedwetting, toe walking, being pigeon-toed, growing pains, leg cramps, tendency to sleep with knees bent, and pain walking up any incline or a hill. On exam, they have weakness, flat feet, maybe a sacral dimple, scoliosis. Hyperreflexia is common, sensory loss. Now, there are also some unusual symptoms of tethered cord syndrome, which is bowel incontinence, headache. Actually, a headache is not that unusual. It's quite common in tethered cord. The stretching can cause severe back pain, tingling, and nausea. Some patients have shocks that go up and down the legs and body, even into the head, and one occasionally burning under the feet. So here's a patient that had a conus medullaris at a normal level. So most neurosurgeons will look at this and say, well, the spinal cord ends at a normal level, so you do not have tethered cord syndrome. They like to see it down around L3. But in this case, you see this large fatty filum, fat in the filum terminal, and that's a good indicator of tethered cord syndrome. Sometimes you see a syrinx in the conus. Often you'll see scoliosis. Sometimes there'll be a spina bifida occulta. These are softer findings of tethered cord syndrome. So after tethered cord release, we saw improvement in neurological function in 11 in most patients. Few patients were worse. This is, again, due to other EDS conditions. But it's been a very successful surgery for us. And very minimal morbidity. There have been no significant morbidities. Perhaps 3% of patients develop a pseudomeningocele, which is a collection of spinal fluid under the skin, which may require reoperation to close a CSF leak. Every patient, with the exception of one, said they'd have the surgery again if they had the choice. Other complications, one had a subcutaneous hematoma, one had a little IV thrombosis, urethritis from a catheter. One patient had a pulmonary embolus. Many patients with EDS have clotting abnormalities and should be on Lovenox after surgery. So in EDS patients, tethered cord is usually a clinical diagnosis, not a radiological one. And in well-selected patients, we get an improvement in more than 85% of patients. Now, there are also issues with brain water in EDS. We typically think of hydrocephalus, and with Chiari malformations, which is a large, big increase in the size of the ventricles. But in EDS, we usually see normal-sized ventricles, and we see what's called benign intracranial hypertension, or pseudotumor cerebri. There's no mass lesion, no real hydrocephalus, no infection. And there have been many etiologies put forward. No one really knows, probably many causes. This syndrome usually occurs in the third and fourth decades, women more than men, headache, visual obscurations, blurring, tinnitus, whooshing noise in the ears, retroorbital pain, double vision, visual loss. If there's visual loss that is predicting, that's patient could go blind, and that would suggest that you want to put in a shunt pretty quickly. But the studies are usually normal, and if you do a lumbar puncture, the CSF pressure is greater than 25 usually. So you treat the underlying cause. Weight loss is actually helpful for pseudotumor cerebri. Diamox, acetazolamide, or Lasix, thiazide, is helpful. Both of these drugs have a sulfur ring, so if you have a sulfur allergy, don't take them. Lumboperitoneal shunt or ventricular peritoneal shunt. Syringomyelia is fluid inside the spinal cord, and it occurs commonly with Chiari malformations, usually goes away after decompression of the Chiari. So this represents deformative stress on the spinal cord. And it can result from other conditions and causes sometimes loss of pain and temperature, sometimes pain, muscle weakness, atrophy. If the syrinx goes up into the brainstem, it can affect the cranial nerves. But syringomyelia is not often a problem in EDS. And occasionally we'll need to put a shunt in to collapse the syrinx. Usually we just treat the condition that caused it, i.e. the Chiari or the tethered cord syndrome. Tarlov cyst syndrome are cysts that arise distal to the nerve root ganglion, most commonly in the sacrum. Most of them don't cause problems. Some of them can cause severe disabling pain. In the sacrum more than lumbar spine, buttocks especially. It's non-dermatomal pain. It can be in the perineum. It can be excruciating dyspareunia or painful intercourse, proctalgia. These pains are exacerbated by anything that increases CSF pressure, standing, coughing, sneezing, Valsalva maneuver, and they're improved by lying flat. There's usually some urinary issues, even urinary incontinence. There may be constipation or rectal issues, and typically there's sensory loss. And Tarlov cysts often occur with tethered cord syndrome, in which case I'd take care of both of those problems at the same time. Pain meds can provide temporary relief, sometimes steroids. You can aspirate the cysts, but they come back. There's a paper we wrote about 14 years ago showing that if you remove the cysts, they go away, and we had about 80% significant improvement in patients. And in conclusion, deformative stress to the nervous system underlies some of the pain and neurologic deficits seen with EDS. The recent consensus statement from the Craniocervical Hypermobility Conference suggests that patients with hypermobility syndromes, like EDS, should be considered for craniocervical instability. In most cases, patients should complete a rigorous trial of physical therapy, activity limitation, medication, and evaluation for other disorders before considering surgery. Surgery is a last option. With careful selection, patients may benefit from correction of the deformity, stabilization, and fusion. But the many comorbid conditions require continued follow-up, and it needs a multidisciplinary team. We need to make precise diagnoses. We need to do dynamic testing, like dynamic MRI. Attention to details and continued follow-up is really important to address all of the many issues. And when arranging for a visit to the surgeon, there should be a primary care physician involved to handle all of these other issues, or a specialist. And the EDS should be confirmed with a geneticist. And the patient should recognize that the full evaluation is usually going to take more than one office visit. It's important often to see the patient on 2 different occasions because they change. And the exam can even change. The follow-up is extremely important. But a good, successful treatment often allows the patient to return to work or study without treating all of the other issues. So I'd like to thank all of my many co-workers and, of course, my patients who have taught me most of what I've just presented you. Thank you for your attention.